Okay, so recurrent pregnancy loss is the most important topic in the part 2 and part 3 as well. So, see, according to the so here we will learn together about the recent new talk 2022 and also about the green talk guidelines. And the main agenda of today's session is how to read the talks. Are you aware of how to read the talks? Anyone? Come on, guys. Someone.
No, doctor.
Right. So, see, you no need to read each and every line in the talk. Just concentrate more on the guidelines. You just need to by heart the guidelines. Guidelines are really important. Those what even my mentor says, guidelines are the Bible for the MRCOG. So and talks, you need to just learn about these green color boxes, which will be mostly 6 to 7 boxes in your talks, every talk. And no need to read all the talks. So last 3 year talks and the most important talks. So these boxes, see here, I have noted the boxes, this one and this one, like this. So every box you read this box. So definitely one or two SBS will come from this box and one EMQ. So mostly try to concentrate on the guideline and then next we will just learn these boxes. So coming to the definition, there are other two definitions from the ASRM, that is American, and one is European guidelines as well. But we'll concentrate more on the RCOG. So what RCOG's new talk saying is the loss of 3 or more consecutive pregnancies before 24 weeks of gestation. It affects the incidence is 1 to 3% of people trying to conceive. This is the according to the recent talk. But according to the GTG guideline in 2011, what they are saying is loss of 3 or more consecutive pregnancies. And again, the updated one is telling it is not necessarily to be the consecutive. So anywhere, if woman is having 3 miscarriages, then it comes under the recurrent pregnancy clinic. Am I clear?
Yes, doctor.
I'm clear so far. Yes. So mostly we will follow the green talk guidelines rather than the talk. So the thing here is the definition is loss of 3 or more consecutive pregnancies before 24 weeks of gestation. We have to note down that this is really important definition because even in the SBA or EMQ they will ask the definition and also incidence, that is 1 to 3%. Usually they say 1% they will give in the exam or 1 to 3% they will give in the exam. And just we will see the rest of the two definitions. So according to the ASRM, it is a clinical pregnancy defined by the ultrasound or histological examination. And coming to the Escher, they will take the HCG plus ectopic or molar pregnancies. They will not include that, but rest they will include. So don't try to remember this, the rest of the two, just concentrate only on the RCOG, right? So
So,
coming to the,
excuse me, I
yes,
want to clarify. What are we taking? Is it 2 or more or 3 or more? Then
no.
is there
So
more? The most.
yes, yes. What they are saying, according to the current evidence, and the UK people are following the 3 or more consecutive pregnancy losses, not 2 or more. But they will start doing some cases, investigations after 2 miscarriages if they think there is definitely a pathological cause.
Okay. So 3 or more consecutive after 24 weeks or before 24 weeks,
Before
correct?
24 weeks, because we call miscarriage before 24 weeks. So definitely 3 or more consecutive pregnancy losses before 24 weeks is the definition. Definitely it is an SBA question.
All right. Thank you very
You
much.
can, yes, no, thank you. So you can expect 1 or 2 SBS or EMQ from the recurrent pregnancy loss. As I told you, this is the most important topic for your part 2 and part 3 as well. So next, who should be referred for review? So in the UK, every specialized cases will have specialized clinics. If the menopause, they'll treat in the menopause clinic. If recurrent pregnancy losses, they will have the specialized recurrent pregnancy clinics. And any maternal medicine cases, they will have their particular clinics. Likewise, so here The woman will be, after 3 consecutive pregnancy losses, the woman will be referred to the recurrent pregnancy loss clinic, where along with the partner, that means a couple will go and they will start doing the investigations and they will do the further management there. All right. So there are 2 types of miscarriages. One is a sporadic miscarriage and other one is a recurrent miscarriage. Sporadic miscarriages is like most commonly they occur in the first trimester. And the most common cause of the first trimester miscarriages is a one definite question. It is an SBA. What is the most common cause of first trimester miscarriages? The answer is fetal chromosomal anomalies. I think this I have asked as a recall question. And the most reason is age. Age is the most important factor in the recurrent miscarriages. And recurrent miscarriages, if it is a chromosomal, then we can say it as sporadic. But if any other cause, including chromosomal or any other causes like endocrine factor involvement or uterine factors involvement, then we can say it directly as a recurrent miscarriages. Am I clear?
Yes, doctor.
Yes. Yeah, clear.
Yes. So tell me who should be referred for the reviews?
Woman who have had three, three miscarriages.
Yes, someone's network is not good. Yes, more than 3 pregnancy loss reviewed in the recurrent
Three
pregnancy loss clinic.
pregnant
Sorry, I don't know
loss.
who is speaking, but yeah, I think your network is not good. Can you please check it out?
Hello?
Yes. So moving to the next. So this, guys, remember this is the most important table. Definitely they will ask the percentage. Definitely you can
Okay, no
expect.
problem. I'll check. Thank you.
Yes. So definitely they will ask one question from this box. So you need to by heart this table. So how I used to remember in my part 2 exam is, so this is the table, 6 see here years, and this is a miscarriage rate percentage. I know you'll think how to remember the percentages and all, but I'll make your life easy. So age, just remember age, a gap is a 4 years for everything. Just you can see. So 12 to 19 years, 4 years, 20 to 24, 25 to 29, 30 to 34, 35 to 39, 40 to 44, and more than 45. Just remember this age, keep it in your mind when you're practicing again. And see, first I used to remember the percentage 11. So I used to write here at the 11, 20, at the 20 years, 11. And then next 11, after 11, 12. I used to write here. Then next 13, next 15. So you can add just a 5 number. Just remember, then you can add 25, double it 50, double it almost 100. So 93. I used to remember in this way till now. I didn't forget, to be honest. So this is my just a tip, but if you have your own way, you can remember in your own way. But definitely they will ask one percentage from any of this. Mostly they will ask it in the reproductive age group like 20 to 29, or they will ask more than 45. So you can expect one SBA from here. This table is really important. Just by heart this table. Sorry, 1 second. Sorry, guys. Sorry. Yes. So anyone tell me how to read this table? Anyone?
Yeah, for the
Yes.
age, I want to say
Yes.
something. After 2019, you'll be adding 20 to 24,
Yes. It's
35 to
11%.
39 to 20, 25 to 29, then 30.
Yes. Yes.
You'll be adding five after 20. So what it means by extreme age, it is 12 to
Ye-
59. Why
Yes.
than
Between
45
this
is
age, the
high?
more
So these
risk
are the
of
two.
having miscarriages. Yes. So between this age, the more risk of miscarriages happening is this percentage. Yes, this is the important table. And next one, coming to the risk factors. So we'll see how why these recurrent miscarriages are happening. So there are a lot of factors like woman's age, partner's age, and their their lifestyles, like their smoking habits, their drinking habits, their coffee consumption habits, their weight, their ethnic, their family background, their ethnicity. So these all are related to the recurrent miscarriages. So let's see one by one. Usually, alcohol intake will increases the risk of miscarriage. Generally, what they say is no more than 14 units in a week. So if it is more than 14 weeks, there is an increased risk of miscarriage. Coming to the caffeine intake should be less than 200 mg per day. So if it is more, again, it is one of the risk factor for the recurrent pregnancy losses. And exercise, if the sportswomen or some women will they do the vigorous exercises, even some in they continue to do in the pregnancies. So regular exercising is really good for health even in the pregnancy, but not vigorous exercises. So this will leads to the miscarriages. And family history of pregnancy losses, so it is still in the research exactly. So family history is also the significant. Maternal age, as we read about this table. So maternal age is the important, first we consider the maternal age most important risk factor, along with the paternal age. Paternal age we take cutoff as a 40. If it is more than 40, increases the risk of pregnancy losses. And any previous pregnancy loss increases the risk. With every simultaneous pregnancy loss, the risk will increases. And smoking, in the smoking, there is if smoking is in the pregnancy, first thing is, uh, there will be a vasoconstriction to the vessels and the miscarriage can happen. And even if the pregnancy continues, they can have small for gestational age babies, fetal growth restricted babies. So for that, smoking is completely not beneficial to the health. And we can say to the woman to avoid smoking in pregnancy. And stress, even some stress depending on their families or the women with these kind of pregnancies, they will be in a lot of stress. So we have to attach them to the counselors to reduce the stress. We will encourage them to do exercises, meditation. So these will reduce the miscarriage rate. And the other one is BMI. So completely they should maintain their BMI between 19 to 25. Anything less or more will lead to the miscarriage. So these are all the important risk factors. So and they can ask anything like caffeine value, they can ask. So cut off in the 200 mg. So they will give you different options like 200, 400, 300 like that. So this is important. Less than 200 should be there. If it is more than 200, it is a risk factor. And even BMI, they can ask in the SBA. So what is the cutoff BMI for recurrent pregnancy losses? So you have it should be like 19 to 25. Even 25.1, they won't accept. Just it should be a 25. Try to remember those points. Yes. So yes.
Sorry to interrupt, Dr. Divya. Could you please slide through?
Sorry.
Sorry to interrupt, but could you please slide through the screen? Because
Yeah, yeah.
there are some students who are saying that they can't really see
Yeah,
the
now
slide. They
can
can't.
yes. Okay, all right. Can they see now? Yeah. Right. So these are the, so next, I told you about the definition, the age related risk, and next coming to the causes, those are the causes, and now investigations. So coming to the investigations, we will take a thorough history from the patient. We need to rule out all these risk factors initially, and then we will start doing the investigations. So in the investigations part, see, first we have to rule out routine blood investigations for the woman, like full blood count, to check whether she's having anemia or not, and her blood group status to rule out the negative blood group. And next we will see the any urinary tract infection she is having. So for that we need to send the midstream urine sample. We need to send, and we need to rule out any endocrinal factors like whether his woman is having any thyroid like hypothyroid or hyperthyroid, Graves disease. So we need to rule out. We need to send even TPO antibodies. and whether the woman is diabetic or not. So for that, we need to check her HbA1c levels. uh these are the investigations. And then we need to do the ultrasound scan, 3D ultrasound. According to the evidence, they're suggesting is to do 3D ultrasound. So if there is any abnormalities in the 3D ultrasound, they will refer to the hysteroscopy or laparoscopy techniques. And they are not in according to the RCOG, they are not recommending any male factor investigations. Only these are the investigations they wanted to check. So let's see all together once again. And just remember one thing: in the first trimester miscarriages, please note down these points. If the woman is having recurrent miscarriages in the first trimester, what investigations she have to go on is: the first one is all the blood tests, all routine tests. Next, she should undergo acquired thrombophilia test, that is antiphospholipid syndrome testing. And the third one is ultrasound, 3D ultrasound scan. In SBS, they can give you 2D ultrasound scan, 3D ultrasound scan, or MRI they can give, or some CTs like that they will give. So the definitive answer here is 3D ultrasound scan. All right. These are the first trimester. If any first trimester miscarriages, you need to rule out this one. If it is a second trimester miscarriages is there in her history, then you need to rule out inherited thrombophilia testing along with these tests. Like inherited thrombophilia is factor V Leiden deficiency, protein C, protein S deficiency. So there are particular inherited thrombophilia testing only you will see only after do second trimester losses you will do. In first trimester you will do this antiphospholipid testing, right? And yeah, come, let's see here. So the investigations here they wanted to do is genetical chromosomal anomalies test. So I will show this table, then it will be easy for you. So here, according to the talk, what they are saying is they are saying that it should be done after 2 miscarriages. But according to the Green Top guidelines, they are saying after 3 consecutive miscarriages, after third miscarriage, the products of conception should be sent for the testing. They will test whether there is any chromosomal abnormality in the tissue, fetal tissue. If this test comes positive, they will send parental karyotyping test. If the parental karyotyping test is positive, then they will refer you to the geneticist. I will repeat once again. After 3 consecutive miscarriages, after third consecutive miscarriage, they will send the products of conception to the tissues to the testing. That is a chromosomal anomaly testing. If this test comes positive, they will send the parental karyotyping to see any abnormalities in both parents. If this comes positive, they will refer to the geneticist. This is a stepwise manner they will do. So you have to remember the stepwise manner. You should not skip any steps in the part 2. This is really very important for your preparation. So just they will ask what is the next step after 3 trimesters miscarriages. What do you do? So that the test is you will do the products of conception testing, and if it is positive, parental testing. If it is positive, refer to the geneticist. All right. So how they will do these products of conception testing? So they will do the karyotyping either by fish technique or array-based comparative genomic hybridization. So these tests will be done in the fertility centers itself. They will just ask the name. Don't try to remember each and every line. They will just ask these names, what test they will do. Okay. Yeah. So that is the one test. And the next step is, as I told you, the hereditary thrombophilia, which means the protein C, protein S, and factor V Leiden deficiency test. This will be done when the woman is having second trimester miscarriage. And the antiphospholipid syndrome antibodies. So anyone tell me what are the antibodies?
They are anti-lupus, anticoagulant, anti-cardiolipin antibodies, beta-1 glycoprotein
Yes, good.
antibody.
Good. So how you will say that it is a
Hello?
antiphospholipid syndrome antibody?
Did you hear
How
me?
you will... Yes, I can hear you. Please,
Okay,
good,
thank
good.
you.
Yeah. So anyone, so how you will diagnose, how you will confirm it?
Say
All
it
right.
again. What I didn't know. I didn't hear what you said, please. What
How
was
you
your
will
question?
confirm, how you will confirm the antiphospholipid syndrome?
Okay, when you have especially beta 1 glycoprotein antibodies
Is one
present,
test is enough to
that's
confirm the
the
diagnosis?
main antibody that is
Is
implicated.
one test? Sorry, I couldn't hear you. I'm sorry. I think network is very bad. I don't know. From my side, it's okay. Yeah, okay. Anyway, I'll tell you. See,
Can I have a take?
and
Hello.
yes,
Yes, I think we have a clinical criteria for diagnosing it, and then we have the laboratory criteria.
yes.
So the clinical criteria, when they have had the two recurrent early trimester miscarriages, or they've had pregnancy miscarriage in the second trimester, especially with the hypertensive disorders like preeclampsia with severe features, for which we had to terminate the pregnancy. And if you have two such pregnancies, then clinically you can say that the person has the antiphospholipid syndrome. In the absence of which, for example, the person has advanced maternal age, and you can't wait for such two recurrent miscarriages, but they have the history of unprovoked thrombosis in pregnancy, then you can use especially the anti-beta 2 glycoprotein antibody to confirm the diagnosis of the antiphospholipid syndrome.
Yes, right. See, so the antiphospholipid syndrome, yes, as one of you said, very good attempt. So antiphospholipid syndrome is defined as these are the antibodies, that is lupus anticoagulant, anticardiolipin antibody, and anti-beta 2, I think beta 1 they said. So it's beta 2 glycoprotein 1 antibodies. So these are the three antibodies should be positive. And one test is not enough to confirm the diagnosis. Okay. So two tests 12 weeks apart will confirm the diagnosis of antiphospholipid syndrome. So this is again one of the most important recall question. So how many weeks apart will do is the question. So it is a 12 weeks apart, two tests should be positive, right? And what this is the criteria for this antiphospholipid syndrome. So three or more consecutive miscarriages before 10 weeks of gestation, or one or more morphologically normal fetal loss after 10th week of gestation, one or more preterm births before 34 weeks of gestation because of the placental disease. So these are all the criteria to fit in, and we have to do a two tests. And the most important is the lupus anticoagulant. It is the most related to the recurrent miscarriages. Okay, so what they will see here is and in the anticardiolipin antibodies they see IgG and IgM found to have the second strongest association with recurrent miscarriage. And third one is anti-beta 2 glycoprotein 1 antibodies. Other third one. So first one is lupus anticoagulant. Second one is anticardiolipin antibodies. And the third one is anti-beta 2 glycoprotein 1 antibodies. And as I told you, the inherited thrombophilias is factor V Leiden mutation, protein C and protein S deficiencies, antithrombin deficiency, and prothrombin gene mutation. All right. Yeah. So these are the investigations we have to do. And next, endocrine, I told you, thyroid and HbA1c need to be tested. And uterine anomalies, I told you. No need to do any male factor according to the RCOG guidelines. Even no need to do any immunological tests.
Ma'am, I didn't get it. You said out of three, it should be two should be there,
Yes,
right?
yes, exactly. See, yeah, I didn't note that point. But yeah, two should fit. And again, the test should done between 12 weeks apart. We have to do two times the test. Okay.
12 weeks apart.
12
Okay.
weeks apart. Single diagnosis is not confirmed. Only if it comes positive, it should come two times positive with 12 weeks apart. That is one SBA question. Okay.
Okay, ma'am. Thank you, ma'am.
Yeah, thank you for your question. Right. And yeah, so as I told you, the uterine factors. So what uterine factors we see? So some like uterine and abnormalities, like it could be a uterine septum, it could be a fibroids. So these could be one of the causes for the miscarriages. In that case, according to the evidence, what they are saying is, even if we do the resection of the septum, the pregnancy rates are not much difference. So nowadays they are not doing any resections. Even they are saying that it will leads to more risk to the pregnancies. So uterine septum resection they are not doing, but they are doing this removal of the fibroids. A woman with submucosal and intramural or subserosal myomas were found to have a higher proportion of second trimester miscarriages, and women with submucosal myomas undergoing resection had a significant reduction in the second trimester miscarriage. So any woman with submucosal fibroids, we need to remove those fibroids for their good pregnancy outcome. Am I clear, guys? Am I clear?
Yes, doctor. Yes.
Yes, thank you. The another cause for the second trimester miscarriage is, you all know the mostly, it is, sorry, it is cervical insufficiency. So this cervical insufficiency, it will mostly happens in the second trimester miscarriages, and it is a painless cervical dilatation. In these women, we need to follow up between 14 to 24 weeks. First, according to the new guidelines, we need to follow between the 14 to 24 weeks. We have to do the cervical length surveillance. It should be less than 25 mm, that is 2.5 centimeters. If less than 24 weeks, we need to offer ultrasound indicated cerclage, and it should be removed at 36 plus 1 to 37 weeks. Sorry about the background noise. Hello guys, can you hear me?
Yes, doctor.
Yes, ma'am.
Yes. Yeah.
Yes, sorry about
No,
the
okay,
background
now I
noise.
was trying to hear them.
Yeah, some celebrations happening. Sorry. Right. So in the cervical insufficiency, this is another most important thing. As I told you, we need to follow the woman between 14 to 24 weeks of gestational age for cervical and surveillance. And if cervix is less than 25 mm, if less than 24 weeks, we have to offer them ultrasound indicated cerclage, and it should be removed at 36 plus 1 to 37 weeks. So it will reduce the recurrent miscarriages. Am I clear so far?
Yes, you are. You are.
Yeah, thank you. Right. So, yeah, moving to the next, these are all talk tables. Yes, even any talk, you just try to read these tables. No need to read each and every line. Okay. As I told you, so diabetes, if woman is having poor control, there is a chances of recurrent miscarriages. And other cause is hyperprolactinemia. Even hyperprolactinemia is also one of the cause, but it is still under the research. So for these women, we need to start giving bromocriptine. We need to rule out this investigation as well, and thyroid disorders. And according to the evidence says, even what is so hyperthyroid is not much related to the miscarriages, but hypothyroid. So hypothyroid will leads to the recurrent pregnancy losses. And according to the recent guidelines, they have changed even the TSH value. Okay, so TSH more than 4, you need to use thyroxine. Even in the euthyroid state, or if just 2.5 to 4, you don't need to use any medications. But if TSH is more than 4, you need to use thyroxine to prevent the recurrent miscarriages. Am I clear so far?
Yes.
Very clear. Very.
Yes, thank you. So these are all the important investigations which, all right. So these are all the important investigations which we need to do in the woman. Okay. Yes. Yeah. So again, the same. So these are the investigations what I told you. So pregnancy tissue, parental karyotyping, 3D scan, thrombophilia, so lupus, anticardial lipin, anti-beta 2, thyroid. Yeah. So these are the tests. And now coming to the treatment. So yes, so for any chromosomal abnormality positive, we will refer them to the geneticist. So geneticist will do the further tests, not the consultant gynecologist. Okay, so what they will offer is they will do the pre-implantation genetic testing. So they will take the egg and they will take the sperm from the partner and they will fertilize the embryo. They will test, and if the if it is with no chromosomal anomalies, so they will do this IVF. So this is the one method which they will do. And for antiphospholipid syndrome antibodies, the treatment they have started is low molecular weight heparin, which is enoxaparin they will use along with aspirin. So aspirin dose should be low dose, either 75 to 150 mg a day. Heparin is 40 mg enoxaparin subcutaneously. So when it should start from the day one of the positive. If today is this start, today they have this pregnancy test and it came as positive, they will start itself today till 34 weeks. So that is the treatment for antiphospholipid syndrome antibodies. And for thrombophilias, they will just give low molecular weight heparin. No need to give aspirin in that. All right. And any uterine abnormalities, if like fibroids, they will remove the fibroids. But for resection, they will just they won't do any other interventions. All right. And any other medical conditions, they will optimize before they have started the treatment. Like if woman is having diabetes, which is poorly controlled, they need to optimize the condition and they will make the HbA1c value to less than 6.5. And if it is more than 8 or if it is more than 10, they won't encourage the pregnancy. They will tell even option, they give the option of termination of pregnancy because there is a more risk of having miscarriages. Am I clear, guys? Any questions?
So what you're saying is diabetes, uncontrolled diabetes, hypothyroidism, hyperprolactinemia, and chromosomal abnormality. These are some of the risk factors that lead to
Exactly.
recurrent miscarriage.
Yes, very good, very good. I really appreciate that. Yes, these are all the causes of the recurrent miscarriages, which should be treated before itself to have a good pregnancy outcome. Okay.
So I have a question.
Yes.
My question is the luteal phase deficiency. You're quite silent on this because we don't have proper treatment for it. That's why we are silent on the luteal phase deficiency, which can be caused by both the hyperprolactinemia and also the corpus luteal dysfunction.
Yes, luteal phase deficiency. Yeah. So for that, they are one second. Yeah. So luteal phase deficiency, this is not they are ruling out anything, but any woman with previous history of miscarriages, and if they are having bleeding, they won't do any investigations. They can give this vaginal micronized progesterone. So how they will give is 400 mg twice daily at the time of presentation with vaginal bleeding and continue till 16 weeks of gestational age. So if the woman is having a miscarriage earlier and now she came with a bleeding, they can start these progesterone tablets even without any investigations. So now they are not doing any luteal phase testings or anything like that. Okay. Is that clear?
Yes, please. You are very clear, madam. Thank you so much.
Yes. So 200 and women with a history of 3 or more previous pregnancy losses, we have to give 200 mg twice daily, starting at the time of presentation with vaginal bleeding and continue till 12 completed weeks of gestation. If there is still vaginal bleeding, we can increase the dose to 400 mg twice daily and continue till 16 completed weeks of gestation. All right. So this is regarding the progesterone. No need to give for every woman. If this is her first pregnancy and if she's having bleeding, you no need to give progesterone. This applies only when the woman is having a previous miscarriages and now coming with the bleeding. All right. Right.
Yes, please. Thank you.
Yes. Thank you. And yeah. So before doing the investigations and doing the management part, first these women has to go through their lifestyle modifications. So they should maintain their BMI between 19 to 25. So and they should stop smoking. They should stop all taking alcohol, and they should limit their caffeine intake to less than 3 cups a day or less than 200 mg a day. And we have to give a folic acid to these women 3 months before conception till 12 weeks of pregnancy, and we need to give vitamin D. All right. And there is also another one called unexplained miscarriages, because even after 3 miscarriages, if there is no absolute cause found out, then we call this as unexplained recurrent miscarriages. So we just give some assurance to the mother, because there is a 70% chance of having successful pregnancy after the 3 miscarriages. Okay. So all they need is just tender love and care. Am I clear so far, guys? Any questions? Any questions, guys?
No question, doctor. You can go ahead.
Yeah. So just a brief. So general treatments, what we have to do is a lifestyle advice to limit their alcohol and caffeine intake, stop smoking, maintaining the healthy
Yeah, quite
exercise
clear.
level. Can you hear me?
Say it again. It wasn't that clear, please.
Sorry. Right. So if maternal BMI is more than or equal to 30, we have to give high dose folic acid should be recommended. This is one of the SBA question. So folic acid 5 mg, where we will give folic acid 5 mg in diabetes mellitus cases, in epilepsy cases, in obesity cases, and if maternal BMI that is more than 30. So this is one of the SBA question you can they can come in the exam. And as I told you, this is a vitamin D supplementation, and some psychological support is needed to these women, because after 3 losses, they will be like, they'll have, even so many women have this post-traumatic stress disorders. So they need a proper counseling. So psychological support is really needed in these cases. And when planning future pregnancies, they should book early in the clinics. So they have to undergo an early pregnancy ultrasound scans, and we will follow with frequent monitoring the mother and the baby with frequent scans. So patients should be reassured that around 70% of patients will achieve a live birth in the next pregnancies after unexplained miscarriages. All right. So to summarize, so recurrent miscarriages are defined as 3 or more first trimester miscarriages. However, clinicians are encouraged to use their even after 2 first trimester miscarriages, if there is a suspicion that miscarriages are of pathological and not of sporadic nature, they can start doing the investigations. Women with recurrent miscarriages should be offered testing for acquired thrombophilia, particularly for lupus anticoagulant and anticardiolipin antibodies prior to the pregnancy itself. They can start. And women with second trimester miscarriage may be offered testing for factor V lead-in, prothrombin gene mutation, and proteinase deficiency. Routine testing for protein C, antithrombin deficiency, and methylene tetrahydrofolate reductase mutation is not recommended. And cytogenetic analysis should be offered on pregnancy tissue, that is the products of conception testing should be done. Once it is positive, parental karyotyping should be offered to the couples, and they have to be referred to the geneticist. So women with a recurrent miscarriage should be offered the congenital uterine anomalies, ideally with the 3D ultrasound, and they should offer thyroid function tests and also TPO antibody testing. No need to routinely offer immunological screenings or infection screenings or sperm DNA testing. They have to maintain their BMI between 19 and 25. They need to stop smoking. They need to limit their alcohol and limit their caffeine to less than 200 mg per day or less than 3 cups in a day. An woman diagnosed with antiphospholipid syndrome, aspirin, low dose aspirin, and heparin should be offered from a positive test till at least 34 weeks of gestation. Yes. And the current insufficient data regarding the pre-genetic testing for couples with unexplained recurrent miscarriages, and resection of the uterine septum should be considered for women with recurrent first or second trimester miscarriages, but it is still under research. Thyroxine supplementation is not routinely recommended for euthyroid women. It should be recommended only when TSH is more than 4. Remember the value 4. This is according to the recent guidelines. And progestogen supplementation should be considered in women with recurrent miscarriage who present with bleeding in early pregnancy, that is 400 micrograms twice daily since the time of bleeding till 16 weeks of gestational age. And women with unexplained recurrent miscarriage should be offered supportive care in the recurrent miscarriage clinics. So that's all, guys. So anyone, any questions?
Yes, please, I have a question, madam.
Yes, please.
My question is on the use of the maternal cell-free DNA as a predictive tool for attempts or this later on in pregnancy and the need for prophylaxis. Where do they come in here? Thank you.
Sorry, can you text this in the chat itself? I couldn't get your question, please.
Yes.
So the chat box, yes.
I have a question, man. Can I go ahead?
Yes, please.
Mine is, when do we do paternal
Sorry, I couldn't hear you. Please text your question. I'll answer you now.
When, at what time? What? Okay, I will.
Yes, please. There is network issue. Please text here. I will wait. Okay, can we get this lecture in YouTube offline? Yes, I think I will ask the team members. So yes, I think yes, you'll get it in the YouTube. Right, next question. What are the indications for karyotyping? Yes, so if the woman is having 3 consecutive pregnancy losses, then that is the indication for the karyotyping test. Dr. Ajnava, sorry, Christopher, I think.
Yes,
so karyotyping
Thank you.
test
So after
should,
3.
yes. After 3 miscarriages, if the doctor unable to find the tissue, they can directly go to the parental karyotyping. That is also another indication. If at the time of abortion they can send, or if there is unable to find the tissue, they can directly send the karyotyping test. I hope it's clear now.
So
Any other questions?
If they cannot find any tissue, that's what they do. But if they can find tissue, what would they do?
Sorry?
You said if they cannot find any tissue, they will go for
Yes,
parental
that means
karyotyping.
yes, that means if women came after 3 miscarriages into the preconceptional clinic, there won't be any tissue, but you need to find the cause. At that time, you can send both the parents to the genesis to find out whether they are having any chromosomal anomalies or not.
Okay, it's
Am I
quite
clear?
clear now. It's quite clear that that's during the preconception. At that time, the thing has taken place. But what if we are seeing the woman at the point it is happening? What will we do? What will be the best investigation, please?
The best test is due to the products of conception testing. This will be done when the woman came in her third pregnancy, when she is having miscarriages. We can ask with her permission, we will do the testing. But when we are not having that situation, we can go this one, directly the parental karyotyping, to prevent the future miscarriages.
Okay, it's quite clear now. Thank you very much.
Thank you. Thank you. Any other questions, please? Yes. Okay. So, ma'am, you taught us that most common cause of first trimester miscarriage is chromosomal anomalies, but not every recurrent pregnancy loss is chromosomal. Did not get this. Okay, I'll tell you. So, if the first trimester miscarriages could have happened, all the 3 miscarriages are in the first trimester, then the most important cause is the chromosomal abnormalities. But what if women have 1 first trimester miscarriages and 2 second trimester miscarriages? It could not have been chromosomal. It could be another cause like either cervical insufficiency or any other thrombophilic disorders. Or other scenario is women can have 2 first trimester miscarriages and the other one is 1 second trimester miscarriage, or even she can have the preterm birth less than 28 weeks or something like that. So if all the miscarriages on the first trimester, then we will think of chromosomes. But if any miscarriages, any other trimester, we can think of any other cause. But according to the definition, what they are saying is recurrent miscarriages means 3 or consecutive miscarriages less than 24 weeks. They are not saying whether the 3 in the first trimester or the 3 in the second trimester. Am I clear? Okay, Samsung. Okay, I think they got clear. Thank you. So please, what about the predictive value of absent? Yes, I'm seeing this question, Augustine Hannah. So please, what about the predictive value of absent? I'm sorry, whoever is speaking, I'm really sorry. I couldn't hear you even a single bit. Please type in the chat box. I will tell you the answers, please. I'm really sorry about the bad network. I don't know why. Okay, Augustine, please, what about the predictive value of absent maternal cell-free DNA for adverse pregnancy outcomes and the need for prophylaxis? Okay, when would one recommend bariatric surgery or SGLT2 for weight reduction to reduce pregnancy losses? Right. So this I will answer. So bariatric surgery, as you know, if woman is BMI is more than 40, directly you will go for the bariatric surgery. And after bariatric surgery, you need to wait for 12 to 18 months to conceive again, or else it would have a miscarriages chances will be more. Or if woman is having BMI more than 35 with any other risk factors like diabetes or any other medical conditions, she can go for bariatric surgery. So this will depend on the team. So they will decide. Okay. And this predictive value, I'm not sure about this question. Definitely, I will get back to in the chat. So I will note down the question and I will get back to you. Okay. Am I clear, guys?
Yes, you are very clear. Can understand you. It's clear.
Yeah. All right. Thank you. So I think that's the end of the session. If you are having any doubts, you can post it in the group. Our team will definitely get back to you. All right. Thank you. Thank you for wonderful time.
When will we have the audio? Today or tomorrow?
Yes, the team will get back to you guys. Sorry. Yeah, they will text you when they will release the video. Okay. Okay, guys. Thank you.
Thank you very much for your time.
Thank you, ma'am.
Yeah, thank you.
Thank you so much, Mom. Thank